Hi, today we're here with Professor Eckart Altenmüller of the Institute for Music Physiology and Music Medicine. We're going to be asking some questions about focal dystonia. So could you give us a brief outline, if you would, of the condition and its characteristics and traits?
Focal dystonia is a neurological disorder, and it manifests itself in a loss of motor control of highly refined and long practiced fine movements of either the hands or the embouchure in brass and wind players.
Okay. A lot of people say it's movement specific or task specific. So people can suffer from a movement which is fine in normal day life, but then as soon as they get to their instruments, then it fails to work. Is that correct? Is that a correct assessment?
It's usually task specific, and that means in musicians it manifests itself only when playing the piano, but not when typing on a computer key, or when playing the guitar, but not when doing fine motor movements in other contexts. So this is one thing which was believed previously that it had a psychological origin. But it's very interesting. It shows mainly that our brain organizes movements in specific contexts. So it's clear that it is a neurological disorder, which is a task-specific focal manifestation.
Okay. Now I'm just remembering now from Leon Fleischer's autobiography when he talks about his dystonia, which was at first like this, but did it not manifest itself into, I think he says that he had problems washing because his finger was curling even during normal activity.
This is a special case. Leon Fleischer had a very strong dystonia, and it would be nowadays classified as a so-called Dystonic cramp. Okay. That means if it's in daily life movements, like washing the fingers or greeting people, and it still manifests in this context, then it is not a task-specific focal dystonia, but it's called a dystonic cramp. This is a further, I would say, progredience, a further manifestation of a more severe disorder. Okay,
so and is that a very common occurrence that happens beyond task-specific dystonia?
No, this is very rare. Usually we say 90% of the task-specific, especially musicians' dystonias, remain task-specific. And there's no generalization towards other fine motor skills.
Yeah. I was going to ask you about characteristics of people who develop focal dystonia. So I've heard that it manifests itself particularly amongst obsessive people. People are very obsessive about their practice, obsessive about the movements, I suppose, economy of movement. And I've also heard that a typical age range is the mid-30s. I don't know how common this is or if that plays a big part or...
Yeah, it's true that there are some special personality traits which are more common in musicians suffering from focal dystonia. So first of all, most of them are very engaged. Most of them are really practicing a lot, hardworking people. Most of them are quite successful also, and they tend to have a perfectionist attitude. And this perfectionist attitude sometimes probably leads to a kind of obsessive behavior in terms of working, practicing, and some of them do not do enough breaks and they do not interrupt their practice schedules sufficiently. However, I have to say also that there are some genetic reasons also which play a very big role, and what is very important, there are many musicians with obsessive behavior and with perfectionist attitude who never develop any kind of motor disorder. So this must be also very clear. In some way, I always tend to try to prevent musicians suffering from dystonia from guilt feelings, because somehow implicitly, if you talk about obsessive behaviors, you feel guilty. Oh, did I spoil my fine motor control or things like this? It's not the case. It's just fate. It can happen to everybody. And so we have also some patients who were perfectly physiologically well behaving, who had a wonderful technique, who had wonderful practice schedules, and even they might sometimes develop dystonia. In terms of age range, tragically, it seems that it is indeed mostly on the height of the career. So if you build up a career, usually you need about 10 to 15 years until you are really in the field. And this means in between 35 and 40. That's the most common center of developing focal dystonia in terms of age frame.
Okay. You mentioned there are some genetic preconditions. Now, because it's a neurological condition that affects the motor skeletal movements, I was wondering if those genetic predeterminers are neurological or physical.
Yeah, the genetic preconditions are neurological, and they are linked to a very interesting phenomenon. Interestingly, our brain has the task to inhibit movements usually. When we refine our motor ability, it starts from early infancy. So when we are very small babies, we know how to grip, we know how to take a small object, but we are unable to move selectively, for instance, the middle finger or the ring finger. So in terms of motor maturation, in infancy, adolescence, our brain learns to isolate finger movements. And this is done via inhibition of the movements of adjacent fingers. And this kind of, we call it lateral inhibition, this kind of lateral inhibition then seems to be compromised if you have a genetic kind of susceptibility, I would term it, of developing a dystonic problem. So this means in the later age, let's say after a lot of work, 32, 35, suddenly the old motor patterns of linking individual fingers together reappears. It's a kind of atavism, it's a kind of falling back to an earlier stage of motor development, what is observed in focal dystonia.
Okay. So an interesting point that I wanted to raise is if there are certain movements within certain instrumentalists that are more prone to dystonia than others. I think Leon Fleischer may speak in his autobiography. I know he certainly speaks about when he was playing left-handed only recitals, he found the repertoire almost more natural for the hand because the melody line was in the thumb, which is a stronger digit. And so then I think he speculated that maybe a lot of pianists get dystonia because they're using the weakest digit to play the melody.
So it's true that there are some risky instruments and also some risky movement behaviors which might provoke or trigger focal dystonia. So first of all, any kind of overuse, that means if you have a very long repetitive activity with the same fingerings, is always at risk. Secondly, it's true that fingers which are by nature weak, if you train them in prolonged time frames, like the ring finger of the right hand in guitar players or pianists, it may be a triggering factor. Finally, any kind of fatigue and reinvestment in this kind of fatigue muscle, that means if you force yourself to overcome a certain muscular weakness, is a triggering behavior. So, and lastly, also any kind of, I would say, psychological pressure which increases the general muscle tone in your body might contribute as a triggering factor.
Right, okay. And how does that relay itself to the brain? So if you're creating this stress, where's the conversation going between the...
Yeah, so if you are stressed, you release stress hormones, the so-called HPA axis, that is mainly a hormone called cortisol. And unfortunately, cortisol has two features. One is it destabilizes motor memories. And secondly, it also weakens the kind of self-repair mechanisms of neuronal circuits. So this is under stress. In some way, you have a very rapid learning, but this rapid learning is destructive and may not lead to a long, beneficial and sustained well-coordinated motor behavior. So this is the reason why we believe that some of our musicians suffering from dystonia have a kind of continuous hate and stress level before they develop dystonia, and this might then trigger the dystonic life. I have to say that, of course, coping with stressors is a task for our whole life. And again, we have a lot of people who are perfectly able to cope with stress. I mean, stresses are all over. You have to meet the schedules. You have to deliver in stage everything you can. You have to be perfect. You have a very limited time frame for recordings and so on. So the stressors are somehow permanent present. Some people are much more able to cope with them, others are not. And those who are not so able with coping, they tend to develop also focal dystonia.
But like we said before, some people have the perfect kind of practice regime.
Yeah.
They do everything correctly, and then they get it.
Again, we have also people which are not stressed at all, and they develop it also.
And I think Gary Grafman, I don't know if you know Gary Grafman.
Of course, I know him.
So he was a friend of Leon Fleischer's.
I know.
And he wrote an article in I think it was the New York Times, and he stresses that he had such a happy childhood. He's really putting the stress on, look, there was no forced learning, there were no deep psychological issues that affected me. So it's obviously, for him to express that, I guess that there's a kind of a stigma attached with this, or that people assume that you've had an internal love-hate relationship with your instrument.
Yeah, but again, maybe he was so strong in somehow putting the stresses aside that he could not admit to have had them. I mean, he was a winner of the Tchaikovsky competition. What a stress. I mean, you go to Russia in the Cold War time, you perform Tchaikovsky concertos in front of, let's say, 2,000 people who, at least in terms of the political way, are your enemies. And you have to convince them with your interpretation. What if not this is stress?
Yeah.
I mean, so I think Gary Grafman, I understand that he felt very happy and felt very successful, but in terms of life events, all successful musicians have to survive very, very strong stresses, strong stresses.
So I suppose then you get into the question of how you deal with the stress. Is it really suppression of the stress, or is it?
Yeah, some people are perfect in just putting it aside and say, "Well, I'm not stressed. I'm quiet."
Yes, yeah.
But then, if you do the cortisol analysis of their saliva, it comes out.
Oh, really?
Yeah, we did a study. We did a study here with pianists with so-called Trias stress test. That's an objective scientific measurement of stress. You induce stress in a laboratory condition. And these musicians, there were some of them who said, I'm completely relaxed. Nothing's happening. But the heart was beating at 120 per minute. And the cortisol in the saliva was at a level so stressed. So they learned to cope with these stresses and to neglect even their bodily stress reactions completely. They believe that they are relaxed, but we measured the heart rate, and the heart rate was very high. Very interesting.
That is interesting, yes. What's the normal heart rate? What should it be? You said it's
usually it's 60 to 70.
Oh, wow. Okay.
So I mean, if I'm nervous, I sometimes go up to 100, I would say, but not more. 120 is quite a lot. That's when I'm running. Then I have 120. So these people, and they neglect this kind of bodily signals. They have developed a kind of emotional detachedness of their bodily signals to perform in kind of liberty, or at least in the facade of liberty. Very interesting.
This is very interesting.
That was by the way, one of our patients who is very successful as a concert pianist, although he is suffering from dystonia.
Really? Okay, so I'd like to move on to some of the common misconceptions regarding focal dystonia, of which I think there are many.
Yes. Yes.
So would you like to kind of tell us a bit, some of the more common misconceptions and some of the really exaggerated misconceptions as well?
So I think one of the most common misconceptions is first that dystonia is not curable. This is simply not true. So if you start and Google focal dystonia, usually you find in the first sentence, focal dystonia is a neurological disorder which is not curable. This is simply not true. So one of the misconceptions is that there's one focal dystonia. There are many types of focal dystonia. There's focal dystonia, which is more linked to, indeed, stress factors and anxieties. And these, of course, can be excellently treated with general stress management and with anti-anxiety drugs. And there are other dystonias which are very strongly linked to genetic factors, where father, grandfather, great-grandfather already were suffering from a form of dystonia. These, of course, cannot, cured with psychological measures, but we have other things. So that's the first misconceptions. So we have to state dystonia is curable. The second misconception is that focal dystonia is a psychological disorder. This is extremely stressful for musicians suffering from focal dystonia because, well, what shall I do if it's a psychological disorder? Where should I go? What's wrong with me? So we need some pragmatic attitude. So the third misconception of focal dystonia is also that it is no disorder at all, that it is hysteria. It's not true. It's an objectively measurable disorder of brain circuits. But what is very important is focal dystonia is learned and it can be unlearned. And this is something we should really emphasize again and again. Our brain is, even at high age, able to relearn, to reprogram, to reformat all these networks. And so it's something which can be unlearned. And so my approach to focal dystonia is that I encourage the patients to seek for the ways they have the best ability to learn and relearn their motor behaviors they had before.
Mm-hmm. That's interesting, yeah. Any other misconceptions?
I think that's the main point.
The main ones to cover. Okay. Now, in terms of relearning, I was just reading an article by a musician the other day who I can't recall who it was off the top of my head, but he was talking about he learnt Braille as a method for kind of the stimulation to the fingertips, which then helped send and resend signals.
Right.
People talk about learning another instrument because you're using, of course, the same area of the brain, the same digits, but of course you're doing different movements on an unfamiliar territory.
Right.
Do both of those sound like good?
Yes. So, in terms of learning, for instance, Braille reading might be very useful because it heightens the awareness of the skin, of the tendons, of the joints, and it somehow gives your brain a lot of information about the position of the fingers. And if I learn the positions of my fingers to perceive this very precisely, even in anticipation of the movements, I'm able to control it. So the way is by heightened perception, by heightened awareness, I'm more able to control the movement itself. And this has been proven. There's one very nice researcher in California. Her name is Nancy Bühl, and she has done wonderful work on this kind of sensory training in order to improve the motor outcome. So what should be, it's very important for musicians to know that the motor system is not like a robot, just being programmed, move, move, move. It's interacting with all sensory organs of our body. And movements are the product of what we hear, what we feel, even what we see. And all these kind of, we call it auditory sensory motor integration processes. They are somehow involved in dystonic movements. And we can correct on all of these single contributors, like we can correct if we have a different auditory impression. For instance, some people have a huge improvement if they have a delayed feedback of their sound production. Other people have a huge improvement if they see mirror of their own fingers. And finally, other people have a huge improvement just by taking a glove and playing with a glove on the guitar. There's in YouTube, I think, one of the guitar players who is taking a glove and who is doing very well with this. It's called sensory trick, but in terms, it's just showing that whenever I'm changing the kind of system comprising hearing, feeling, seeing, moving. Whenever I change one of these compartments, I will change my symptoms.
Oh, that's very interesting. I was recommended by a friend to try some mirror techniques.
Yeah, people do it, and it might be helpful. But again, as I told before, every dystonia is different, and this is now, if you suffer from such a disorder, there is a solution. You will be able to relearn, but you have to find your own way. It's individual. And though that's why I mistrust all this called recipes, if you come to me, I will cure you. It's some responsibility. I like to give back to the patients to consider their own problem as a kind of individual research case study, doing research in the movements and the things which work and which do not work.
No, that's very interesting. When you mentioned about the senses, and you're stimulating the senses through reading Braille.
Right, yeah.
So I noticed, I want to come on to your treatment methods later on and what you prescribe. But I know with me, you've prescribed Trihexyfenidyl.
Right.
Now, when I take this drug, it's quite a powerful drug, I think.
I think it's a powerful drug, yeah.
Now, I've noticed my sensations are different. Is there any link here? Does that heighten sensual awareness in any way, shape or form?
So the medications we use, Trihexyfenidyl, is interacting with the sensory processing and also with the motor processing, and this might be one of the beneficial effects it has. Furthermore, Trihexyfenidyl is a very good medication to reduce the stability of the dysfunctional sensory motor networks involved in dystonia. So it gives you a better access to relearn and to reprogram your movement.
Okay, so a big question I wanted to ask you was, there seems to me to be a broad definition of cure in the sense that certain people who claim to be cured, it seems to me they're actually working around the problem. So obviously, if you have a leg amputation and then you learn to walk with prosthetic limb, you haven't grown a new leg. You're kind of working around the problem, but you can still get from A to B. And so, that's probably not a good analogy, but I wanted to just explore a little bit the concepts of cure, and whether you should be aiming for a cure in the traditional sense of fixing the problem.
That's a very good question. What is a cure in musicians' dystonia? So, pragmatically spoken, for me a cure is when I'm continuing my profession, when I'm continuing performing, when I maybe even improve. But of course, this might imply some reduction of repertoire or some modification of repertoire and also some changing of fingerings and so on and so on. This would be a pragmatic cure. And there I can tell you about 70% of our patients, and we have seen more than thousands, can be named cured in this way. There are some musicians who are not simply cured, but even perform better and have better control of their movements after dystonia, due to the fact that they, for the first time in their life, were really thinking about the movements, were really analyzing the movements, and were somehow perfectioning the movements. So there are, I would say, a percentage of about 10% of my patients who really objectively play better after dystonia than before. Mm-hmm. And then there are some patients who really regain their old motor patterns, but in most patients it is a kind of modification of technique. So it turns out that the posture is somehow a little bit modified. That are simply, or that frequently, these are very subtle changes, but they modify posture, finger positioning, things like this, or they modify embouchure a little bit. But in the terms of outcome, I would say a cure indeed is when I can continue to perform, gain my money, have an income, and maybe even improve in my everyday artistic activity. Mm-hmm.
Something that I've found interesting, that I'm kind of still playing with, I'm still experimenting with, is this concept of what I labelled outsourcing the technique to the subconscious. So I really concentrate on something else. I turn away from the right hand. I'll be thinking of sound technique, maybe listen to on headphones with some reverb or some altered.
Right.
So I'm really taking away.
Yeah, it's good.
My consciousness of the movements of my right hand. Does that sound like a good?
This is a very good way for motor learning. There's a scientific labeling. It's called the so-called external focus. And it seems that external focus, that means not thinking about the movements, by no means thinking about the muscles, not thinking about where is my finger now, but just listening for what you're producing or paying attention to what's going on with your fellow musicians. This is very successful, and it somehow fosters and supports sensory motor learning. So try, whenever you are able, try to put an external focus. It's very interesting also that many musicians who are still performing report that they are much better in public appearances than when they are practicing at home. Mm-hmm. And this might be in fact due to the fact that they put much more external focus when they are on stage. You know, they are just, how am I, how is it sounding, what are the people around, how do I get the message across? Yes, and they are not so much focused on their own right hand and the middle finger and the ring finger. This is just something which musicians have learned. When they perform, they have an external focus.
Mm-hmm. I've noticed that with myself with certain repertoire.
Right.
That it's, it certainly helps and I think because you're naturally taking the view that you mentioned a minute ago about really what you need to do is get through this gig. You need to make that piece sound well to the public. So forget about, getting the right movement, forget about even if that's your focus during your daily practice, which it shouldn't be. You put it aside for that live performance, which is really what you're saying. You should extend that philosophy into your daily practice.
Right.
And then, that's a very interesting point. Now, I wanted to ask you about a patient's recovery is not typically linear.
That's true.
You're not going to get day-on-day improvement throughout a period of time.
No.
And I've experienced this myself, where I have, just last week, in fact, I was in Salt Lake City. I was invited out. I was staying in a lovely part of Salt Lake. I was invited by some friends to have a recording studio, and they wanted me to record on a track. But I arrived on, maybe Sunday, and we recorded Wednesday or Thursday. I had a few days there in this relaxed environment, and I was playing in the morning. I had no pressures, and I was getting better and better and better every day. And I was really happy because, of course, we're here today to get another injection of Botox.
Right.
So I was so far from my last injection of Botox, and I was playing at the best I had since the Botox injection.
Excellent.
So this was all really good news.
That's good, yeah.
For 3 or 4 days, I continued to improve. And then I did a recording for them, which is kind of, in the studio environment. And then the next day, it had gone again. I was back to, I could barely move. And part of me thinks I should have then taken a rest for a day, because it could also be more physical, maybe fatigue. But what I'm expressing is that it seems so it's a delicate perch. It's sort of, and then you're kind of back to where you were a little while ago, which is obviously disheartening. But I'm trying to, remind myself that this happened previously, and then I climb back up. Yeah. So my question here is really that although we have this uneven, non-linear improvement, are there any typical patterns? Do people kind of get good for a while, then lapse, or are there certain? Do patients come and tell you about their past month, and you notice patterns between various patients that?
So, I mean, this is a very interesting observation you made. This is very individual. There are people who benefit a lot from regular practice without breaks, every day 20 minutes of basic exercises, just finger movements, just finger positions. And then there are other people who benefit quite a lot from kind of boosting practice, 3 hours, 4 hours, that make a break of one day and then work again. This has to be found out by every patient. It's not predictable. It's not predictable. We do not know exactly what in our brain is going on. The point is that most of the motor learning happens offline. That means not while you are practicing your guitar, but in breaks in between, during night sleep. And this is something we really do not know what our brain does. So I think in this time, the motivation, the dopamine, you somehow release because you were looking forward to have this wonderful performance session and this recording session with your friend. The dopamine somehow increased the learning. And then somehow it was, when the motivation was lost because it was over, in the kind of release, it was just the learning was somehow fell back in a previous stage. It's not lost. What you have learned is somewhere in your brain, and you will be able to tackle it again. So don't be afraid of this. It's a very good sign that you were able to perform, that you were able to record, and even though you had the other days a kind of drawback, it's not a bad sign. It's just showing that the system is somehow not predictable and it's very adaptive.
Okay. There's something there interesting that you said. You said that we think that we're trying to improving only when we're playing.
No,
but we
it's
also
offline.
You said the breaks and the sleep, but I think previously you may have said to me that even when we're doing a separate activity,
yes,
even with our fingers, so we may be learning a different motor complex, but we're still processing the previous practice. And I think you said as well that, and this is, I think, a really good point for people who want to continue playing while they recover, is that we can store 2 or more motor memories, so we can have a performing safe mode,
exactly,
and then be recuperated.
So we are perfectly able to have a performing mode, even with some dysfunctional movements, just getting around, and at the same time re-establish a new motor program. Our brain has this huge capacity of, let's say, a sort of parallel pathways, and we can have both pathways at the same time. So I think that is very important for many patients, that they believe I should take a break and I should do not perform anymore. And this increases so much the life stresses. No income, no contact to the friends, being alone, just working on rehabilitation and retraining. This is so demotivating. This is so, I would say, and for many people, it's extremely discouraging. So I always say, try to play. Go on, do what you can. Try to adapt the repertoire, try to ask friends to take over difficult parts, and so on and so on. But do this on one side to reduce life stresses, and on the other side, take your time to re-establish somehow your technique. And this will be a net gain. You will really improve, because then you have several ways of how to play.
So a colleague of ours suffered from hyperacusia. And as we were talking about focal dystonia, it reminded him of his experience with that. So the question, are they related? Are there any parallels between these conditions?
These conditions are very similar. Hyperacusia, musician's dystonia, chronic pain, tinnitus, they are all learned conditions. It has to do with brain networks which are functionally somehow corrupted, and they can be relearned. And the point is, the best way to relearn them is to trust into the capacity of our brain to adapt. That is brain plasticity. And our capacity of learning is for the whole life present. And you can, even when you are 104 years old, you can still rely on brain plasticity. Wow. So this is our topic here in the Institute. That's what I'm living from, brain plasticity.
Now, brain plasticity is a little bit in vogue at the moment with an author. I can't remember his first name, but I think his surname is Deutsch. He's written a couple of books. And he talks about, I think in one example of pain, he said that areas of the brain that are left dormant for a while will then be taken over by other areas of the brain. And I think he talks about, say for example, if you haven't looked at pictures for a year, then your kind of, the part of your brain that analyses those pictures is left dormant, so then the pain can spread to then make the pain greater. So then kind of, I think a cure that he was trying, or in this story, is about as soon as you get the pain, if you start looking at pictures, then it kind of reminds that part of the brain what its original purpose was, and then it's no longer producing pain.
This is this was the famous first experiments on brain plasticity in the early 90s. It was done with phantom limb pain. And indeed, one of my friend, Professor Bierbaumer, he could nicely show that indeed, if this was the limb which was missing, because it was, of course, phantom limb, that means it's after amputations. If the limb was big, large, represented in the brain, it was painful. But as soon as it was somehow filled in with activity and mental, images, then this pain was reduced. Again, chronic pain, phantom limb pain, but also chronic regional pain syndrome in the hands. These are all learned disorders. So pain in itself, in the beginning, of course, is a signal of the tissue that something is not going very well. But at least after 6 weeks, we start to fix the pain in our pain memory. And then we need to have good experiences with the aching limbs, with the hands or with the shoulder and so on. And then we can override this dysfunctional memory of pain. It's very similar to focal dystonia. It's very similar.
Yeah, that's very interesting. And I'd just like to finish with talking about your general advice, or your advice to musicians who are wanting to embark on this, what could be a very long journey, or could not be such a long journey, to recovery, to whichever definition we may use of cure, whether it's kind of circumnavigating the problem or curing the problem. You've already mentioned that cases are individual, but there must be some maybe philosophical issues that you may like to...
So I would give the following advices to somebody who is suffering from dystonia. First of all, stay optimistic. You will overcome it. That's very important. It's not incurable, it's curable. It's a learned disorder and you can unlearn it. That's the most important part. The second thing is, don't put too much pressure on you to become healthy again. If you have time pressures, take your time. Nobody can really know how long it takes. It may take months, it may take years. So just be open for this. Third, stay inventive. Try out everything and see the good points in it. It's finally time to get some wrap up of your technique. It's time to meet some new people. It's time to make new context. It's time also to experience your own life and to maybe put some questions to yourself. So see also the positive sides of dystonia. And then finally, don't believe in, let's say, guru-like behaviors or people who really say to you, oh yes, it's no problem, I can cure you. Mostly there's some truth in it and it might work for some people, but as I said, every dystonia is different, every patient is different, and there's a huge variety of approaches, and it's a task for every patient to find this way for himself.
There's no one size fits all.
No, there's no one size fit. Exactly.
And it's interesting when you touched upon it earlier about people actually becoming better musicians than before.
Yes.
Because there are obviously factors that lead to dystonia, and those factors could be compromising your playing before you...
Exactly, and then you will overcome it, and then you start to think about your technique, you start about the sound, you start to think about your working behavior, you start to think about, well, what did I do? How did I approach people? How did I interpret things? It's a lot of gain. And if you think about somebody who is really severely, hidden by dystonia, like Leon Fleischer, the last works he played, I mean, when he's playing Brahms, the piano quartets, there's such a depth in it. There's such a kind of profound knowledge of emotions. And in some way, he has gained so much that in some way, probably he would never have become such a great pianist without dystonia.
That's interesting.